second day of the resident and student presentations, and so welcome and for support of each other and all that. That's wonderful. I actually, except for the AV glitches yesterday, I think the presentations went really well, and the students did a wonderful job, and even the residents did a pretty good job. So we're going to start. This is Karina, and you did tell. Is it Tien?
Tien.
Tien.
Close enough.
All right, so we're going to try to keep on time because I understand there's breakfast simultaneously as here. So if you want to, we want to get out of here in time to get some leftover breakfast if there is any. At least I do. Yeah. Okay. So anytime.
Okay, so my name is Karina Tien. I am a PGY1. I'm currently finishing my transitional year at Coral Health Taylor. So today I'm going to be giving a talk about understanding the ocular risks of eyelid and eyelash beauty trends. So before we start, we're going to talk about just general eyelid anatomy. As you know, the eyelid is the thinnest skin in your body. There are 7 structural layers of the eyelid. It starts off with your skin and your subcutaneous tissue, and within your subcutaneous tissue, that's where your glands of Mole are, your glands of Zeiss, as well as your eccrine sweat glands and your sebaceous glands. And then under that would be your muscles of protraction. The main muscles for that would be your orbicularis oculi, and then your orbital septum, and then your orbital fat. When you have any eyelid penetrating lacerations, when you are determining if it's gone through the orbital septum, the most common identification is if you see the orbital fat layer. And then below that is your muscles of retraction. For your upper eyelid, that would be your Mueller's muscle, and then your levator aponeurosis. And then for your lower eyelid, that would be your capsulopalpebral fascia. And then lastly, you have your tarsal plate. That's where all your meibomian glands are. There's about 25 to 40 meibomian glands within your upper eyelid and around 20 to 30 within your lower eyelid. And lastly, your conjunctiva. And then there are about 75 to 80 lashes within your lower eyelid and about 90 to 160 within your upper eyelid. So the first beauty trend I'm going to talk about is your eyelash extensions. This is very common, especially in younger female patients. They are typically comprised of a synthetic fiber or a natural fiber that is then applied with an adhesive. Most adhesives are cyanoacrylate based, and they will contain some latex as well as ammonia. It's also known to be high in formaldehyde-emitting products, and this is a concern because the U.S. Drug Administration, as well as Human Health Services, has identified as formaldehyde as a carcinogen. So with that involved around your eyes, that's not really the best. So then in 2018, there has been known to be a new product called magnetic adhesives used. This is mainly used because a lot of female patients, they don't want to keep on getting lashes applied like just a one-time based. It's used for reusable eyelash extensions, but the concern with that is if the patient doesn't know how to clean them properly, you are at increased risk for any ocular infections. And then the other concern is that it should be avoided for any MRI imaging or MRI procedures. Typical ocular complications are allergic blepharitis. You also have some contact dermatitis, conjunctival erosions, as well as mechanical consequences. The mechanical consequences are only present when you are doing it with an esthetician. Eyelash extensions, you can do it by self. You can get them over the counter, or you can have an appointment with an esthetician. And with that, it's when you're applying it, as they're applying it, you can cause some lag ophthalmos, as well as the gel pad that you see right here. That typically contains a preservative as well, and then that can cause some periorbital swelling too. Next, we're going to talk about is your eyelid tattooing, or also known as your blepharopigmentation. In Detroit, we have a huge Arabic population, so this is very common in our Arabic females. When I was in Colorado, I also saw it in a lot of Hispanic communities. It typically involves distribution of pigmentation along your cilia and into the superficial dermis. As any tattoo, it involves like a round tip needle and various ink pigments containing copper, aluminum, or titanium. The only concern with this is tattoo ink, since it is a cosmetic procedure. It's not FDA approved or regulated. And then there are ocular risks include like allergic reactions such as your allergic granulomatous reaction, conjunctivitis, and then there's also a concern for eyelid penetration, tear film instability, as well as meibomian gland dysfunction. The severity is very dependent on needle depth penetration as well as the patient's own allergic reaction. And then the last one I'm going to talk about is your eyelash tinting or dyeing. This can be done by self. It can be done over the counter, but most of the time people go to an esthetician to do it. A lot of people prefer to do this because it mimics like a eyelash darkening principle of mascara. But the concern is most dyes do contain many chemicals. For here, it's listed as stearic acid, acetyl alcohol, triethanolamine, as well as 2-chloro-p phenylethylamine. The ocular risks for these typically are, as well as any like chemical-induced reaction, is contact dermatitis, periorbital dermatitis, edema to the lids, and erosion, as well as ulcerations to the cornea. In 2006, there was a case study series that identified a specific brand of eyelash tinting dye that caused silver deposition within your eyelid margin as well as your conjunctiva. They saw that if you use recurrent dyeing, it will cause some corneal agarrosis as well as conjunctival agarrosis. So then lastly, this is just a table summarizing all the complications with these 3 most common beauty trends. As you can see, most of them are just allergy reactions to the dyes used. But yeah, and thank you for your time.
Just a comment for someone, who didn't know about these kind of things until I ripped them off of people's eyelids when I was, flipping them for to looking for foreign bodies, or even I had a lady in her late 60s who had this, who somehow made it all the way to cataract surgery, and I'm over there trying to do the speculum, and I'm ripping her eyelashes off, and oh my God. But she said, no, I'm not upset, thank goodness, because I'm good, because I'm going to stick needles in your eye now.
Yeah.
Great. All right. Well, thank you very much. That was a nice little summary. All right. Finally, we got Kyle, right? And you are also a resident. Correct. Same program. Wow. Yeah. Smart people in that program, huh?
All right. Well, good morning, ladies and gentlemen. Thanks for being here. Excuse me. So my name is Kyle Welbum. I'm one of the PGY3s over at the Beaumont-Taylor program, I guess now known as Corwell-Taylor. And today I just wanted to keep it kind of more of a light, interesting topic, talking about the history of ocular transplants. And when I say that, I mean history of everything that's ever been transplanted within the eye, first time it's been done, what's being transplanted now. Transplants are a big topic of interest for me personally, and so I thought this would be a fun one to touch on. And so, there we go. We'll go ahead and start at the front here with the eyelids and eyelashes. So the first reported transplant of eyelids, including the entirety of the eyelid and the lacrimal system, was actually done fairly recently in January of 2010. This was done in the Mount Sinai Department of Ophthalmology. Since then, there have been several other ophthalmologists that have replicated this and had good results. And so that's something that's probably going to be continuing to gain more interest and it can become more common, I guess, as time goes on. The first reported transplant of eyebrows was actually done by a Japanese dermatologist, Dr. Okuda, in 1939. And he would use small patches of hair that he would then just graft onto the eyebrows. But since then, the technique's evolved, and now it's done more as like individual hair follicles. And that's what's typically done today. As far as eyelash transplantation, that was first done by Dr. Parashar in the US in 2006. Now, that original transplantation was done using scalp hairs, but more recently in 2015, Dr. Umar of California started using leg hairs, and he found that that was actually superior to the scalp hairs. And so that's been starting to gain some traction as well, interestingly enough. He found that just the curvature and the way that they function as eyelashes worked better than the scalp hairs. talking about the conjunctiva, the first conjunctival allograft was performed by Dr. Robert Thoft of the U.S., and that was used in an attempt to repair eyes that had been affected by chemical burns or thermal burns. But this has continued to evolve, and it's still used today, but it's largely overshadowed by the use of autografts nowadays. Autografts were first reported from doctors Kenyon, Wagner, and Hedinger, who are all affiliated with the Harvard School of Medicine. And these were initially used in pterygium surgery, actually, as a way to help prevent pterygium recurrence and help improve the outcomes, especially with regards to the scarring that they'd see sometimes afterwards that affected the extraocular muscles that would sometimes cause some diplopia. And they found that that cut down on those complications. In terms of the sclera, the first reported scleral allograft was performed in 1961 by Dr. J.H. King. He was a military ophthalmologist, really a smart man if you look at his research, but he was treating a case of chronic scleromalacia perforans and ended up having really successful outcomes with this and documented his research really well. And so these types of grafts are actually still used today for cases like scleromalacia perforans. They're not super common, but they have been used and are very successful. And it's actually a relatively similar technique to what Dr. King originally described. The first autograft was performed by a Swedish physician, Dr. Larsson, several years later, and this was in an effort to repair actually a corneal perforation. So this was not transplanted onto the sclera, but more onto the cornea side of things. So this is still used, but it's a little bit of a different technique now, we'll just say. As far as lenses, there's really no recorded cases of anyone trying to transplant an entire crystalline lens from one eye to another, which is not really something that we need anyways, so that's all right. And then as far as iris transplants, there's no published reports, but there's some theoretical reports that the first corneal transplants were also done by the same guy that did an iris transplant, but those had very poor results and were not worth continuing. The first recorded IOL implantation was from Sir Thomas Ridley in St. Thomas Hospital in England. Really an interesting story. It was originally made from PMMA after he noticed that an implanted fragment of PMMA from an air pilot windshield went into the pilot's eye but didn't cause an inflammatory reaction. So he said there might be something to this. We could use this for IOLs, and we went on from there. Anterior lens capsules were actually used for transplantation starting in 2016, but not really transplanting to other lenses, but rather transplanting to the same eye, and this is for repairing refractory macular holes. They were found to be really successful and have started gaining some popularity within some areas of the country within retina specialists. As far as vitreous transplants go, there was a first recorded case back in 1946 performed by Dr. Iyer and his colleagues. It was a way to try to replace intraocular volume from prior surgery or prior trauma. Obviously, these had very mixed results, not something super easy to transplant vitreous, and vitrectomies were not really the same then as they are now. So now with the current advent of vitrectomies and the way that those are done now, we have a lot of other synthetic materials that are used for the eye instead. And then moving on finally to retinal transplants. The first partial thickness retinal transplant was performed by Dr. Ernest of Chicago, and that used fetal RPE cells that were transplanted into eyes with AMD. Now, it showed promise, but it really failed to demonstrate long-term benefits. There have been several subsequent attempts to replicate this procedure and to try and perfect it a little bit more. And some of those studies have shown promise, but nothing conclusive long-term. And so that's actually an active area of research to see if this could be a more definitive treatment for AMD. And then full-thickness autologous retinal transplant was first performed with Dr. Mahmoud from our institution at Beaumont ARC back in 2016. He would take an area of peripheral retina, and then he would use it to try to repair refractory myopic holes. And that's something that's still done today and has continued to be shown as highly successful for these types of holes. And that is your brief overview. Thank you very much.
Any transplants that you ran across?
Nah, I didn't see anything for nerves.
Nothing for nerves?
Yeah, I mean, there was the case in New York of transplanting the whole eye with the nerve, but that was obviously not successful. I ended up NLP. There were some studies that showed that there was some type of information going to the brain, but nothing that was beneficial to the patient, so.
And just a little aside, I actually, during my training, actually met Dr. Burns. He had a textbook out that we used, and I was an optometrist before I went back to medical school, and during optometry school, I got a chance to meet him, and actually we used this book in optometry school, so.
That's way cool.
Yeah.
Yeah.
None of the other ones from the 1800s, I didn't know. Okay, thank you very much, and the next is Brian Wynn, also resident. Yes. Same program, I do.
Yes, all from the same program. Good morning, everyone. I'm Brian. I'm one of the PGY4 residents over at Beaumont Taylor, one of the co-chiefs along with Dr. Gao, who some of you met yesterday. Today I'll be taking you guys through a grand rounds case of an interesting patient we had about 2 years ago. But let's see if we can make it through here. All right, so we have a 35-year-old Caucasian female, history of epilepsy, anxiety, depression, tachycardia, and chronic alcoholism, presented in clinic with sudden onset persistent vision loss in both eyes for the prior 2 months. Notably, she had a previous hospital admission prior to symptom onset for both visual and auditory hallucinations that were associated with chronic alcohol use. Now, during that admission, she was started on IV thiamine supplementation for suspicion of Wernicke encephalopathy. And it was during this admission that she first noticed her vision changes occurring in both eyes. Now, she otherwise denied any other visual symptoms, no eye pain, no flashes of light or floaters, no total vision loss, but she did, again, endorse that significant visual blurring. She hadn't been taking any vitamin supplementation since being discharged from the hospital. And, unfortunately, in our patient demographic, especially greater Detroit area, sometimes access to medication and resources is limited. So just going through her basic exam here. So her pupil exam was benign. She had no RAPD noted. Her visual acuity was 2100 in the right eye and 2200 in the left eye. Now this was uncorrected visual acuity. After a manifest refraction, she did correct to about 2050 or 2040. Full EOMs, full confrontational visual fields. She otherwise denied any previous ocular history, but that being said, her red desaturation test was positive in both eyes, and more so in the left eye, meaning when she looked at a red cap that we had, she said it looked very pale in both eyes, but it was more noticeable in that left eye. And I actually apologize for this. I left off her intraocular pressure was I believe normal. It was in the low teens. It's the only important thing. Glaucoma is the most important thing. On her physical examination, her anterior segment examination was relatively benign, but on her posterior examination, it was obvious that she had demonstrated some optic nerve pallor, especially temporally in both eyes. Here's a fundus photograph of both eyes, and for those medical students in the room, so if you want to pay attention to these temporal crescents here, of the optic nerve, where it obviously looks a little bit more pale than the rest of the nerve, and those are the areas of suspicion there. That's not supposed to be like that. And when we did an OCT of her retinal nerve fiber layer, few numbers to look at here. So these numbers at the top are the average RNFL thickness of the nerves. They should be in the 90s or above, but you can see the right one is in the borderline zone. I think it's 77 microns or so. And the left eye was about 91. When you look at the breakdown, the right eye, there was significant thinning noted inferiorly and temporally, whereas now while the left nerve looks relatively normal, if you take a closer look at the numbers, there is some thinning temporally of that optic nerve. These were her visual fields from her initial visit, and while her reliability indices were good, meaning she took a good test, so low false positives, false negatives, and fixation losses, and it's very subtle, but if you take a look at some of these numbers, which might be a little bit harder to see, she's demonstrating a mild superior arcuate deficit in both eyes. Now, this is a little bit unusual, and we'll talk about this in a little bit as far as why and why the differential doesn't necessarily play into this, but it's kind of just an interesting presentation. All right, so the differential for bilateral optic neuropathy is absolutely massive. Of course, the most important one, it's the only thing that matters in ophthalmology, it's glaucoma, but we won't really talk about that because that's not necessarily pertinent in our case. So at the top of our differential is a toxic metabolic etiology. So we were thinking that she's demonstrating these visual changes because of a vitamin deficiency secondary to her chronic alcoholism. And most often, we'll talk about this in a little bit too, is because of a deficiency in B-complex vitamins. Now, there's other things you can think about too, and when you approach any field of medicine, it's always important to establish a wide differential. So hereditary causes, which are less likely, are Leber's hereditary optic neuropathy versus an autosomal dominant optic atrophy. Again, earlier presentations would be more common with that. A demyelinating process, ischemic process like an NION or a posterior ischemic optic neuropathy. Could it be a compressive issue, like with a mass? No history of trauma, so obviously trauma doesn't seem to be high on the differential. And you always have to think about your infectious and inflammatory etiologies as well. So nutritional deficiency optic neuropathy, it's a relatively uncommon cause of optic neuropathy. It usually presents insidiously over a period of months with symmetric bilateral visual field loss. And this is why patients do not present with an afferent pupillary defect, because you see that there's this vision loss in both eyes. They also tend to present with dyschromatopsia, meaning you don't see colors very well, so that's where that red desaturation test comes in. And then they tend to present with central or secocentral scotoma. So central scotoma, pretty self-explanatory. Secocentral is a visual field deficit that extends from your blind spot into the center of your vision. And so this is what I more or less expected to see on the visual field testing, which is why the RQ deficits were a little bit odd. Common nutritional deficiencies, like I was mentioning, were the B-complex vitamins, as well as copper. And high-risk individuals, those who are strict vegans or vegetarians, those with inflammatory bowel disease, history of bariatric surgery, those with pernicious anemia, malnutrition, or chronic alcoholism. Now, the thought is that B-complex vitamins aid in the production of ATP, which is crucial to mitochondrial oxidative phosphorylation. So you guys can kind of put that together. A relative absence of these vitamins would lead to mitochondrial dysfunction, and overall that allows the accumulation of free radical species and damage to the retinal ganglion cells. So treatment, obviously, is repleting the deficient vitamins in a timely manner. And B-complex vitamins are easily available in oral form, and in hospitals they're available intranasally, sublingually, subcutaneously, and intramuscularly. Now, for our patient in particular, with a more reversible cause like chronic alcoholism, or those who are drug-induced or have poor diet, a short-term oral therapy is usually sufficient, of about 2 to 3 months time to replete these vitamins. But visual prognosis is really dependent on how quickly these patients receive the vitamins and also the duration of the vitamin deficiency in the first place. And so for our patient, who was a chronic alcoholic of several years and also did not have access to these vitamins outside of that short supplementation in the hospital, prognosis wasn't great, but her vision is still very functional, 20/40, 20/50 vision. And most experience spontaneous recovery closer towards baseline vision if intervened on soon enough. We did do an extensive lab workup for her too, and this is a huge infectious and inflammatory panel. Few things resulted positive. I think her lysozyme was just slightly elevated. We didn't think too much of that, and her HSV IgG as well as CMV IgG were mildly elevated, but again, that does not suggest active disease. We would be looking for IgM at that point. So this is all to say the labs were relatively normal. And visual field, because I'm a glaucoma guy, we like that. Not a lot to see here, and obviously everyone likes to use the grayscale plot to try to visualize what the deficit is. And I'll kind of just break it down for you guys, and especially for the medical students out there. So a couple numbers you can kind of cheat on are the mean deviation and the pattern standard deviation. A bigger negative number in the mean deviation suggests a worse visual field deficit, and a bigger number for pattern standard deviation would suggest, again, a worse visual deficit. So over the subsequent months with appropriate vitamin supplementation, you can see a modest improvement in her visual field deficit, but she still does kind of demonstrate a bit of a relative lack of sensitivity in the superior arcuate region in both eyes. So the MRI, the last thing we got here, just want you guys to pay attention to the pons here and that little hyperintensity. The radiologist actually interpreted that as a progressive central pontine signal abnormality suspicious for central pontine myelinolysis. Now, the medical students in the room are probably closer to this than us, but one of the main or the classic cause that you're taught is rapid correction of hyponatremia, which the patient didn't have, so it was a very interesting presentation, but chronic alcoholism can actually do this as well. So just kind of a interesting case all the way around. You know, neuro-ophthalmology is a challenging thing, and again, the differential is always huge, but yeah, that's the extent of my case.
Great. Thank you. So, sure.
So history is very important, and you have to see, especially pediatrics, because I've been involved, autistic kids, or even just kids in general, they're picky eaters. You ask about, what do you eat every day? Is it just toast every day, you know, and butter, or just a pasta diet? You're gonna see this, and you're gonna miss it if you don't ask.
It's just like anything that's white, so like bread, toast.
Pasta, yeah.
So the vitamins that kind of are branded as, like, they will help your vision, are they mostly just B complex vitamins, like the ones for macular degeneration, that's the A-REDs?
Yeah. So funny enough, A-REDS does not have that. So A-REDS has, you know, vitamin C, E, copper, zinc, and A-REDS 2 is like lutein and zeaxanthin. So it actually does not have any B complex vitamins in there. That's why, you know, those are great for macular degeneration, especially the A-REDS study, you know, proved that it helps progression of more advanced stages of macular degeneration. But for the general population, usually like just a multivitamin will get you there. And you know, again, our patient population in Detroit, you know, you see this a lot, where patients are just, you know, excessively consuming alcohol and they're not really paying attention to nutrition. But yeah, A-REDS vitamins actually do not have any B complex vitamins. Yeah.
And I actually have an answer for why they were arcuate instead of Central, because unfortunately that patient probably didn't read the textbook and just picked the wrong as, you know.
They're just making our life harder.
Yeah,
That's
well,
what it is.
they're just, you know, they should have consulted with you first and then.
Yes,
figured
and
out.
then we can figure it out together.
Then,
Yeah.
yeah, exactly. All right, thank you very much. All right, is it Melanson? Melanson, oh, David, I know you. I didn't know it was your last name.
Interestingly, with my last name, Louisiana is the only place where they pronounce it right the first time, so. But I don't mind the mispronunciations. Well, yeah, I'm David Melanson. Thank you all for being here early in the morning, whether it's in support of others or to learn a little more about the eye, about these topics. So my topic is a little more specific, yet I hope there's pieces in here for anyone interested in any part of the eye. So specifically, I'm talking about implications of patients with celiac disease when they're considering corneal refractive surgery. Corneal refractive surgery, because it's a little more of an elective, because of its elective nature, but again, there's things in here that can be applied to any patients. So corneal refractive surgery, just going over it really quick. The basis of corneal refractive surgery is And I'll kind of go over myopic, although you can do it for hyperopic patients as well. But you're getting through the epithelial layer, getting to the stroma, and you're using a laser now to level out the cornea, kind of plateau it down to correct their vision. And I have 3 different forms on there. The big differences is just how you're getting through the corneal epithelium. LASIK, now the most popular that we hear about, you're cutting kind of a flap, flopping it open, getting to the stroma. PRK, you're just taking out the epithelium in general, and then you have a contact lens you put in afterwards as epithelium regrows. And then SMILE, you're cutting out a lenticule, and then you make a little side lesion pulling that out. That was just a 1-minute quick thing. If you want to know more about it, Parker Lawson's presenting on it tomorrow, and we'll go into a lot more depth. But just kind of so we're all on the same page with that. Celiac disease, we all kind of know what celiac disease is, and I didn't want to go too in depth into it. But understanding that it's a malabsorption disease, so you're going to have a lot of commonalities with several others, like Crohn's and such. And it's really common. It affects 1 in 133. I'm sure we all know people with celiac disease. If we're practicing, seeing plenty of patients with celiac disease. And it's often misdiagnosed too. So even people that we didn't know have it, have it. And that's kind of some considerations with it. And why I wanted to touch on it with this topic, because we'll all see patients with it, and they may even ask, okay, doctor, how is this affecting my potential surgeries then? This is based on a literature review I did, so I didn't want to dive too deep into here, but here's just some of the, as I did the systematic review, some of the things I went through, some of the databases I used, and the terms. I made that really long so none of you wanted to read it. No, but yeah, some of the terms, and then the initial search results I got, and then I expanded on it from there. Oh, that moved a little weird. It should say ocular surface. Sorry, the line is cutting over a little bit. But as I go through it, I'm going to go through some different parts of the eye as I'm presenting, organize it that way. So starting with the ocular surface, obviously important for corneal refractive surgery. The first thing is dry eye, which being a malabsorption disease, that makes sense, getting some vitamin A deficiencies and such. It's important with corneal refractive surgery because that can sometimes be a complication. So just a consideration as you're thinking that, as they already might have dry eye and it might complicate it further if they get the selective surgery. And then, interestingly, one of the findings from one of the studies is that they had a lower endothelial cell density. And so using specular microscopy before on these patients, before they get corneal refractive surgery, just to make sure that's not the case for your prospective patient. As corneal refractive surgery, corneal refractive surgery can also sometimes lower endothelial cell density as well, and the risk there being, as I've listed, corneal edema, if that endothelial cell density is too low. Some other aspects too, with vitamin A deficiency, you get things like corneal lesions, Bateau spots, and a delay in wound healing, which obviously is important for surgeries. Moving on to the anterior segment, with the Scheimpflug imaging, which I'm sorry, I probably just mispronounced a little bit, there was several studies that looked at this and found differing results. That's why I didn't list them on here. Some found that there was no difference in any of the measurements in ACA or the anterior chamber density as well. Some found that it was increased and some found that it was decreased. So just understanding that there could be a possible variability in those celiac patients, not necessarily increased or decreased, but especially with the ACA and ACD. Lens density changes, that's more specific to cataracts, but again, something to consider, especially if they're having to get IOL and you're already having to do a refractive surgery, another piece of the puzzle to kind of put together. Uveitis 2, I'm going to talk about type 1 diabetes as well. Just celiac disease being an autoimmune disorder, so there's a higher chance of other comorbidities with autoimmune disorders, several of them causing uveitis. One of the studies put uveitis at celiac patients, there's about 1% of celiac patients who have uveitis. So again, another thing to consider. With the posterior segment, there's some more vitamin A deficiency considerations. We already had a little bit of topic on vitamin B complex and some of the effects there too, with it being a malabsorption disorder. Obviously consider those. I have some specific findings on here, but just kind of the biggest thing to consider with it is the risk in causing lower best corrected visual acuity. So again, you're trying to correct, with corneal refractive surgery, you're trying to correct these people's vision, how much vision is really being able to be corrected if you have some of these other effects, including thinner central macular thickness and such. And then the final point there too, celiac disease being comorbid sometimes with type 1 diabetes. So not only do you sometimes have type 1 diabetes more often, and obviously with ophthalmic patients, you're going to be asking about that because of all the effects with it. But sometimes they can compound as well, increase together. And celiac patients with type 1 diabetes, in the study that I found, have an even higher prevalence of diabetic retinopathy than patients with type 1 diabetes alone. And then neurological manifestations, these are some of my favorite to learn about. Really interesting. Gluten ataxia. So those that have celiac disease will sometimes have the anti-gliadin antibodies that will attack Purkinje fibers in the cerebellum, as well as sometimes peripheral nerves, causing gluten ataxia. And then also opsoclonus myoclonus, there was a case study that found that in someone with celiac disease. And the big issue with this and relating it to corneal refractive surgery is if they have nystagmus or they're not able to keep their eyes steady, that makes it really hard when you're trying to do a laser surgery and get that precision that you want. And then I have the reference here. All of the studies were found in this. So this was the literature review I did. And then, yeah, any questions?
Very nice. Celiac disease is, so variable that, so some people probably have minimal to any.
Exactly. Some
whatever
people have none
any
of that.
ophthalmic findings.
Yeah. And luckily, a lot of people here have for the vitamin deficiencies, they're able to get it taken care of a lot quicker. Where if you're in countries that don't have that, you might have some of those. Yeah.
Correct. All right, great. Thank you. Jacob, is it Brucker? Yep. All right, Shorts, a man after my own.
Hey, good morning, everyone. Today we'll be talking. Yeah, thank you. Today we'll be talking about traumatic chorioretinopathies. I'm Jacob. I'm one of the residents from Dayton. This is a list of topics. We'll hit kind of the high points. I know it's a pretty short lecture, so we'll just hit the high points of all these. The first one is commotio retinae. This is a self-limiting widening of the neurosensory retina. It can appear at the site of trauma or contralateral to the site of trauma, which is indirect. What happens in commotio retinae is there's disorganization of the photoreceptor cell layer and the outer segments more specifically. This disruption can lead to edema if it's present in the posterior pole. If it's present in the posterior pole, it's considered Berlin's edema, and you get this glistening gray white opacification of the neurosensory retina. Berlin's edema can look like a pseudo-cherry red spot, and on an OCT you can get some hyperreflectivity and thickening of the ellipsoid zone. Here's an example. The picture to the left shows that gray kind of glistening, and then the picture on the right is what Berlin's edema looks like with the pseudo-cherry red spot. Symptoms, most likely none. You can have some blurry vision. Treatment, really nothing. Most people gain recovery pretty quick. Sometimes it can take up to 6 months. Next is Purcher retinopathy, first described by Otmar Purcher in 1910 after one of his patients actually fell out of a tree and he had some vision loss. Purcher retinopathy is from trauma. There's also something called Purcher-like retinopathy, which has very similar retinal findings but without trauma. Purcher-like retinopathy is seen usually in acute pancreatitis, fat embolism, some orthopedic surgeries. The pathology, it's thought to be from microembolisms of the retinal vasculature that leads to arteriolar occlusion and infarction of the nerve fiber layer. The signs are, the most common one is cotton wool spots, found in 93%, retinal hemorrhages, and then the pathognomonic sign is Purchar-Flecken. This is polygonal areas of retinal whitening with a clear demarcation from the affected retina. Sorry, it got cut off there. And then the surrounding arterioles. It'd be better to show you here. This is both Purchar retinopathy. You see some retinal hemorrhages, and then the polygonal areas in between the arteriolars of the arcades, that's Purchar-Flecken. That's the pathognomonic sign there. Symptoms can be nothing, can be some decreased visual acuity, some visual field defect. On OCT, you'll see inner retinal layer hyperreflectivity from the cotton wool spots and a variable degree of macular edema. There's really no evidence-based guidelines. Some people try high-dose IV steroids. The outcome's variable, but about 54% regain 20/20 vision. Next is traumatic macular hole. This is a full-thickness defect of the neurosensory retina at or near the fovea from an external force. It makes up about 1 to 10% of all macular holes. The typical demographic are the people that are more tend to be in traumas, so young males. The pathology, anterior to posterior compression with equatorial expansion of the globe induces tangential attraction. This typically occurs immediately after the injury, but can take weeks to occur. Signs, a round or ellipsoid full-thickness defect with a rim of subretinal fluid involving the macula. And on imaging, you can see a complete retinal thickness loss with cystic retinal changes. And on FA, you can see some central hyperfluorescence with window defect. Here's a good example of an OCT. There's a full-thickness macular hole. And here's a fundus photo. Management, observation, about 40% can spontaneously close over 2 months. Around 60% can close after 6 to 9 months. If they don't spontaneously close, you can do a pars plana vitrectomy with peeling of the ILM, placement of gas to relieve the tractional component, and about 90% closure rates with PPV. The prognosis is fair. 50% attain 20/40 vision or better. Next is choroidal rupture. This is a break in choriocapillaris, Bruch's membrane, and RPE. High-risk activities include martial arts, tennis, motor vehicle accidents. And how choroidal ruptures occur is compression with rapid hyperextension of the globe causes stretching and ultimately breaking of the choroid, Bruch's, and RPE complex, but the overlying neurosensory retina is still intact. You can see this crescent-shaped yellow-white subretinal streak that's usually concentric with the optic disc. You can see some associated hemorrhage in the sub-RPE or subretinal space. Symptoms really depends on where it is. If it's in the periphery, it may be asymptomatic. If it's in the macula, you can have some pretty poor vision. On imaging, you get, on the OCT, you get loss of continuity, the RPE at the site of rupture and thinning of the underlying choroid. And here's that kind of whitish concentric changes you get with a choroidal rupture, and kind of changes in the RPE as well, or loss of continuity, I should say. Management, observation with Amsler grid. These patients are more likely to get C and V, so you need to have them do Amsler grid. Prognosis depends where it is. If it's in the macula, not a very good prognosis. If there's C and V, also not a good prognosis. Next is chorioretinitis scloptaria, also known as traumatic chorioretinal rupture. The word is derived from Latin, and the person that actually found it named it after handgun in Latin after the patient sustained a gunshot wound. This is a full thickness rupture of the choroid and retina with an intact sclera. On signs, you get bare sclera with associated subretinal or vitreous hemorrhage, the adjacent rupture of retina and choroid, and you get decreased vision. Here's a nice picture of it right down here. So intact sclera, everything else ruptured. Rupture through the choroid, RPE, and retina on OCT, management, observation, and fix anything else that can be fixed. Prognosis, the defect can improve on its own, and only about 16% of patients achieve 20/20. Traumatic retinal detachment, this is separation of neurosensory retina from the RPE. The most common cause is rhegmatogenous, And the most common predisposing lesion is retinal dialysis, which is a retinal tear or separation of neurosensory retina from the non-pigmented pars plana epithelium at the aura. Classic signs of retinal detachment: new onset flashes, floaters, curtains of vision loss, loss of red reflex. Here's an example. This is an example of retinal dialysis. Last one, shaken baby syndrome. This is non-accidental trauma or abuse. In about 6% of reported cases of child abuse, an ophthalmologist is responsible. It affects about 1,400 children per year. The pathology occurs secondary to forceful shaking of an infant toddler. They think the retinal hemorrhages occur from rapid acceleration, deacceleration forces that causes damage via vitreoretinal traction. Other hypothesis, hypoxia, increased intracranial pressure. Signs, starting at the front, you can have periorbital trauma leading to ecchymosis, orbital fractures, anterior segment, hyphema, cataract, corneal laceration, posterior segment, vitreous hemorrhage, retinal detachment, optic nerve avulsion, macular retinoschisis. The brain injuries can lead to nystagmus, cortical blindness, cranial nerve palsy, subdural hemorrhage. The biggest sign of shaken baby syndrome is hemorrhages in all three layers. This happens about 85% of cases. And you get these dome-shaped hemorrhages, which is easier to see here. So bleeding in all three layers with kind of dome-shaped hemorrhages is classic for shaken baby syndrome. Management, prevention is best. If something is consistent with shaken baby syndrome, you should urgently send to the emergency department for a full workup. Prognosis poor, but depends on the severity of the central nervous system trauma. Pupillary reactivity is a poor prognosis factor. 15% of cases suffer from cortical blindness. Kind of a sad one to talk about, but one of the causes. Here's my references.
Thank you. That's and actually for the medical students, I've seen all of these, unfortunately many of them multiple times. In your career, if you're doing ER call and things like that, which most of you will be doing, you'll wind up seeing all of this stuff. So it's not, he doesn't talk about, it's not very obscure things. It's things you will actually encounter. Okay, and we have one last presenter, Danny Ocular, young lady.
And we have breakfast.
Yes, and we'll have time for breakfast.
Okay. Good morning, everybody. I'm Danny Ocular. I'm a third-year medical student at Rocky Vista University, and I'm hoping to match into ophthalmology this season. Today I'm going to be talking about stromal corneal dystrophies. So stromal corneal dystrophies, within the cornea, there's 5 layers, 6 if you count duas. These are very rare, but they're a genetic disorder. The 4 most common are granular, macular, lattice, and Reese-Bucklers. A common mutation is in the TGF-beta1 gene. There's many types of stromal dystrophies. These are the ones we just see most common. The only exception I have here is macular, which is a gene CHST6. That one is so hard to say. I've said it so many times and I miss it every time. But these are the most common ones. They each used to be diagnosed based on how they looked, so they all look a little bit different. Granular has kind of a snowflake pattern to it. Macular is a more diffuse haze. Lattice and Reese-Bucklers both have a more lattice, lace-like look to them. So you can still absolutely see that, but the genetic mutation is very helpful. Right now I'm currently working on a meta-analysis of these because there's not a lot of clear guidance on what to do with these patients. I've been looking at these 4 dystrophies when we get to a more invasive procedure, so looking at PKP, DALK, and PTK. And then what are those visual outcomes going to be for these patients? At what age do we need to start doing some more invasive procedures for them? And the biggest problem is going to be recurrence. Because this is on a gene-level mutation, recurrence is a really big problem for these patients. It's going to affect all of their epithelial cells and keratocytes. So even if we do a full cornea transplant, eventually the host cells are going to repopulate, reintroducing the mutated gene and causing this to reoccur. A lot of times these patients are diagnosed when they're children or in their young adulthood, and so it really is a lifelong battle. We might start with drops or contact lens patches and maybe even do corneal scraping. But one thing I find interesting is that TGF-beta is increased in childhood, and so that makes sense to me that we would find it in early childhood. And then another thing is that it's increased during trauma. So, I mean, it's like a cat chasing its tail, right? I want to do a corneal scrape so that we can get rid of this, but at the same time, that's probably going to increase your TGF-beta, which is the most likely genetic mutation. So it sucks for these patients, to be honest. Recurrence, like I said, is the biggest problem. And the literature on it is very varying in this, and there's not one big meta-analysis. So I really hope that this is going to be helpful for future clinicians. But as you can see, this is a graph of each of the 4 dystrophies with the 3 treatments that I've been looking at. There aren't any literature for DALK, for lattice and macular, or for lattice and respuculars, so that's not 0. There just isn't any literature. But over half of these are above or at 50%, which is unfortunate for the patients. Macular is my favorite since it's usually only recurring about 30%. So hopefully you have a macular patient. The other thing is that when is this going to recur, right? So for granular, we generally are going to see recurrence early in the first 5 years with these patients. If they do make it past 5 years, you can have a conversation with them that it's not likely to recur at that point. But I think that this will be helpful information for individuals and for physicians talking to their patients one day. And then another thing that's important is talking about the visual acuities and when to start these. Like I said, since they're usually diagnosed when they're young, it's important to talk with your patients about when should we be doing this type of thing. And on average, we're not usually seeing these till about 30s or 40s, depending on the severity. There are definitely case reports of doing these in very young children, but on average, this is about the age range. For all of them, we have pretty good post-op results, which is great. And macular, we generally tend to see surgical interventions sooner, or maybe not sooner, but when their visual acuities isn't quite as poor or compared to the other ones, which I think makes sense because recurrence rate for these isn't as high as the other ones. So I think that's a really good clinical choice. Overall, though, clinical decision-making for stromal dystrophies is quite difficult. And I think that there is currently not very clear clinical guidelines on what and when to do something with these patients unless they're asking for it or they're complaining a lot. And especially through this meta-analysis, I found a lot of heterogeneity in the literature. I mean, I think my I-squared is like 98, which is showing a large heterogeneity, which is not great, unfortunately. And I hope that we can work on that over the next few generations. But ultimately, I want to help guide better clinical decision-making with this meta-analysis. And really, in my dream world, there would eventually be some standardized reporting that we could do with these and potentially collaborative registries across the nation. I think that that would be awesome if this could start some initiatives on other rare eye conditions to start kind of pooling this information together. And I think that that would be really great for clinicians, researchers, and ultimately really benefit our patients. So our key takeaways today are that stromal dystrophies are inherited, they're lifelong conditions, and they're very difficult to manage. There is currently limited literature and few guidelines for surgical decision-making. The analysis I'm working on will hopefully fill in the gaps and offer some practical insight for better care. And then eventually, if we could have standardized outcome reporting, that would be very transformational for these patients and for the future of research. Thank you so much, you guys.
Well, thank you very much. The only comment I have is that's one of my toughest areas because it's all pattern recognition when you're looking at the cornea, and when it's obvious, it's obvious. But when it isn't, it's hard to figure figure out which one they actually have type of thing. So
Yeah.
that's why I never went into cornea. But thank you very much. And everybody did a great job today, and everybody ran on time. AD worked perfectly. Everything went really well. So we have a few minutes before we start, I think, with pediatrics, right? Lecture. So we have time. At what time?
Yeah, 7 o'clock.
7 o'clock. So I have time to get breakfast. Thank you.